Hello, this is Dr. Patrick Davis. I'm a bariatric surgeon here at the TriStar Southern Hills Center for Surgical Weight Loss. I'd like to thank you for your interest in this program. This presentation is designed to give anyone a little bit more background information on what surgical weight loss looks like and who it might benefit. I always like to include a little bit about myself for my patients that are coming in to see me and that are about to tell me all about themselves. I'd like them to know a little bit about me as well. I am a native Tennessean. I grew up in Chattanooga. I went to undergraduate and medical school at the University of Tennessee. I then spent the next 6 years in Winston-Salem, North Carolina, where I did a 5-year general surgery residency at Wake Forest School of Medicine and then a 1-year fellowship in minimally invasive and bariatric surgery. As part of that fellowship, we also did weight loss, and in which I performed over 150 bariatric operations as the primary surgeon. After I finished my training, I then moved to Columbia, Tennessee, where I created a very successful bariatric surgery program where we had a lot of great success and helped a lot of patients out. And now I'm honored to be a part of the TriStar Southern Hills team. So I'd like to start off a little bit by talking about what obesity really is. Obesity is a disease. It's something that we have now come to terms with as being more than just any type of life choice. This is a progressive, life-threatening disease, and it results from the abnormal deposition of fat throughout the body. Morbid obesity is defined by what's called a body mass index, which has to do with height and weight of greater than or equal to 40, or between 35 and 40 with certain health conditions. Morbid obesity is severe obesity at which serious medical conditions can occur or even be made worse. Obesity has now become the leading cause of preventable death in the United States. It has surpassed smoking, which is an interesting thought whenever we consider how much time and effort is spent in smoking cessation, but very few people want to address the problem of obesity in our society. The one thing that we do understand now, as I mentioned before, is that this is more than just any type of choice. This is truly a disease with many different contributing factors, including genetic and metabolic components, as well as environmental issues. Some of these obesity-related diseases that can be greatly affected by one's weight are things like arthritis. Simply, the more weight one carries, the more pressure it puts on your joints. Acid reflux, the more intra-abdominal pressure there is, the more it pushes things back up the esophagus. Certain cancers have a higher predisposition in those that are overweight. Diabetes is certainly one that we see very frequently. Depression, fatty liver disease, heart disease, high blood pressure, sleep apnea, even issues with urinary incontinence and venous stasis, all can be contributed to by one's weight. This next slide is one that is somewhat busy, but it is on there just to kind of give one an idea as to what their BMI stands. And also during these presentations, I like to somewhat create a typical patient that we can look at. So in this, if we had a 5'6" female that weighed 247 pounds, that would give her a BMI right at 40, which would classify her as being morbidly obese, no matter what medical problems she may have, if any. We will then take that number and also look at what is the ideal body weight. Ideal body weight is a number that is, in many cases, unfairly low, and it only takes into account one's height and gender. And so what we use in bariatric surgery often, just to give people a better understanding as to what to expect, is what is called the excess body weight. And how we determine that number is you take the current weight of the patient and you subtract the ideal body weight. So for our 5'6" female, her ideal body weight is 130 pounds. And if you remember, being 5'6" and 250 pounds put her at a BMI of 40, so she has 120 pounds of excess body weight. It's almost an entirely other person from the ideal body weight standards. So why are we here talking about surgery? Well, there are lots of different ways to go about weight loss. There are non-surgical treatments and surgical treatments. Non-surgical treatments is a very broad category. It includes things from just plain diet and exercise to fasting to medically supervised weight loss with pharmaceutical agents. And what we see with that is usually about a 10% loss of excess body weight. Now, whenever we look at those and we follow those patients out for years at a time, we see that over 95% of those patients end up back at their starting weight. There are certainly those that do lose a good bit of weight with these attempts and keep it off, but the vast majority of people do not succeed with non-surgical weight loss alone. The benefit of this, of course, is that it is very low risk, minus some of the risk of the pharmaceutical agents. Surgical treatment, on the other hand, for weight loss carries with it a much higher success rate. What we see is generally, as opposed to 10% loss of that excess weight, we see anywhere between 50 to 80% sometimes of that excess weight loss. And then the failure rate, or what we call weight recidivism or weight regain, even when you look out 10 to 15 years, is generally less than 20%. So 1 in 5, yes, over the long outlook, can gain their weight back. The vast majority of people lose weight, keep it off, and go on to live healthier lifestyles. But one of the best parts of surgical weight loss is the either improvement or complete resolution of medical comorbidities. All of those, that laundry list of those medical problems that are affected by weight loss, get better, if not completely go away. But oftentimes the one hang-up that patients have with this is that it is a surgery. Surgery does have its own risks, but this has become a very, very safe operation. We will touch a little bit more on the risks associated with surgery a little bit later on in this presentation. So when we talk about surgery, we talk about who is the ideal surgical candidate. In order to be a surgical candidate, you have to meet the NIH, the National Institute of Health, criteria for bariatric surgery. Now, truly, this is ultimately up to the insurance companies, but they all tend to abide by these guidelines. And what that is very similar to the previous definition that we discussed, which is a BMI of 40 or a BMI of 30 or higher if you have certain medical problems. Things like uncontrolled or difficult to control hypertension or high blood pressure, obstructive sleep apnea if you have to wear CPAP at night, or type 2 diabetes. There also has to be a history of weight loss attempts. Surgical weight loss is never the first step in attempting to lose weight, but oftentimes by the time people make it to my office, needless to say, there have been a multitude of attempts made at standard dieting and exercise and even supervised weight loss with less than satisfying results. We also talk about, of course, no psychiatric contraindications. And what that means is those people that have difficulty making decisions for themselves. That does not include things like anxiety or depression. That's more along the lines of personality disorders and things of the such. Another very important thing for who is a surgical candidate is the necessity for complete smoking, tobacco, nicotine cessation. That is a hard line. If we are going through such means to make you a healthier person, we have to exclude such unhealthy habits like smoking or any type of tobacco usage. Not only from an overall health standpoint, but the usage of those greatly increases one's chance of having any type of complication with surgery. And the absolute most important thing to success in being an ideal candidate for surgical weight loss is the dedication to this lifestyle change and the dedication to follow up with instructions from your surgical weight loss team. I would now like to touch a little bit on our specific program at TriStar Southern Hills. What I offer with this program is a multidisciplinary patient-centered approach. That's a fancy way of saying I've got a whole big team that wants to work with you and create a program that's centered around you, the patient, for the best chance at success. So in this team, of course, is myself. Emily Cornwell is our lead dietitian for the program. We have an entire team of physical therapists, my office staff. I have a dedicated surgical team in the operating room. There's dedicated nurses and a dedicated floor for my patients. We also use the assistance of behavioral health and licensed psychologists, as well as emotional support groups. This is a big change, and there oftentimes are a lot of other things that come into mind when it comes to making a big lifestyle change, and we have all the resources at your disposal to ensure success in this program. With this program, we are going to be offering 2 different types of surgeries here at Southern Hills. When we look at surgical options for weight loss, we characterize them in 2 different ways. The first is restrictive and the other is malabsorptive. Restrictive is exactly what it sounds like. It works by appetite restriction. Malabsorptive means that it actually changes the way that your gut sees the food that you eat. So the 2 operations that I offer are the laparoscopic vertical sleeve gastrectomy as well as the laparoscopic Roux-en-Y gastric bypass. The laparoscopic vertical sleeve gastrectomy works entirely through appetite restriction. It is 100% restrictive. The laparoscopic Roux-en-Y gastric bypass also works mostly through restriction. About 90% of the weight loss with the gastric bypass comes through appetite restriction. About 10% is characterized as malabsorptive because there is some change in the way that your gut sees food, and we'll talk about that a little bit in this next slide. The laparoscopic Roux-en-Y gastric bypass is the gold standard in terms of surgical weight loss. It has been the most researched. It is not the oldest operation, but it certainly is the one that has been around the longest. Again, as stated before, it works through about 90% of the weight loss is restrictive, and only about 10% comes from the malabsorptive side of things. And I use that malabsorptive word carefully. This operation in itself does not cause poor nutrition. It does reroute things a little bit, and so that your gut sees food in a different way. As illustrated in this picture, a small pouch is created from the upper portion of the stomach, which becomes the new functional stomach. The rest of the stomach, otherwise known as the bypassed or excluded stomach, is still in place and connects down to the duodenum, which then receives enzymes from both your liver and your pancreas, which then travel down the channel marked with the green arrows, while your food goes down the channel marked with the red arrows. As you can see, things seem to meet up further downstream where the mixing occurs, which allows for digestion. Now, there is still ample small intestines past this connection, and so we do not have issues with the absorption of nutrients with this procedure. It is the bypass of that input of the pancreas and the bile that really sees the benefits and creates the 10% malabsorptive side of this. And it greatly benefits, especially those patients that are insulin-dependent diabetics. The bypass of that pancreas and biliary input has been shown to alter the gut hormones to greatly increase one's sensitivity to your own body-made insulin. The other thing that's good about this operation is that it is the ultimate anti-reflux operation. You are excluding the bottom portion of the stomach where the majority of the acid is made, and so it does not reflux into the esophagus. With the Roux-en-Y gastric bypass, what one can expect with this surgery, the surgery itself takes about 2 to 3 hours, sometimes less, sometimes a little bit more. The only reason I say a little bit more, sometimes some people have something called a hiatal hernia, which is a small hernia in the diaphragm where the esophagus goes through. If that is the case, this has to be fixed at the time of the operation and adds a little bit onto the operating time. Generally, patients are in the hospital 1, sometimes 2 nights. Patients are drinking the afternoon after their surgery. We get everybody up and walking because walking is one of the greatest keys to a speedy recovery. In terms of medications, generally small tablets are still well tolerated, and any changes to medications will be dealt with by myself and our pharmacy team and reviewed with the patient in detail prior to discharge. The potential risks of the Roux-en-Y gastric bypass are very low, but present nonetheless. When we talk about risks with the gastric bypass, I break it down into the immediate risks and then the long-term risks. The immediate risk has to do with things like wound infection, the potential of a leak from one of the connections, the possibility of blood clots, and then, of course, unfortunately, anytime we talk about surgery, there is always the chance of mortality. Now, that risk is very low. That risk is low along the lines the same as a joint replacement or even a hysterectomy. The long-term risks of the gastric bypass include weight regain. Anytime we operate for weight loss, there is always the chance of, again, what we call weight recidivism. That has a lot to do with patient follow-up in compliance with our system, but that is always a chance. With the gastric bypass, there's also the risk of ulcers and the possibility of stricturing or narrowing of that connection of the stomach pouch to the small intestines. This also creates a necessity to avoid things like smoking and non-steroidal anti-inflammatories. That includes the majority of the over-the-counter pain control products, things like ibuprofen, Motrin, Aleve, naproxen, Celebrex, Mobic, meloxicam. All of those things, unfortunately, become lifelong no-nos for those patients that have had a gastric bypass because they can create devastating complications. The one issue that a gastric bypass can create is the potential for things like hernias and bowel obstructions. Anytime anybody has a prior abdominal operation, there's always a risk of scar tissue, which can create obstructions. And also with the gastric bypass, we are rerouting things a little bit, which creates new somewhat bridges and overpasses, and things can potentially sneak under somewhere and get stuck in a way that requires possibly other operations. Now, again, that is very few and far between, but it is a risk that the gastric bypass carries that the sleeve gastrectomy doesn't necessarily have. Another thing that people talk about a lot with the gastric bypass is something called dumping syndrome. This has to do with the small intestines are now connected to that gastric pouch, and those intestines are not used to receiving stuff straight from the stomach. And so certain things can cause fluid shifts in that intestines, which can lead to abdominal cramping, sweating, dizziness, and even possibly lightheadedness. But in a way, I'm somewhat hesitant to call that a complication, as that's really more your bypass is working, and it's reminding you of the things that you are not supposed to eat. And so although it is an uncomfortable sensation, it is not truly anything wrong. It's somewhat of a reinforcement of appropriate dietary choices. I do also put on there vitamin and mineral deficiency. This is a problem that we have dealt with in bariatric surgery for quite some time. However, over the last 10 to 15 years, the laparoscopic gastric bypass has become much more standardized, so that this has almost become a problem of the past as long as our patients maintain compliance with their vitamin and mineral supplementation. So thankfully, that's not something we have to deal with very much anymore. Our next operation is one called the laparoscopic vertical sleeve gastrectomy. Now, this is a little bit simpler is the way I would characterize it. Some patients seem to characterize it as less invasive, but in reality, both of these are laparoscopic surgeries. They both are major life-changing surgeries. I would not consider one less invasive versus the other. In this surgery, I remove basically 75 to 80% of the storage capacity of the stomach. And that is done by removing the side portion of the stomach, which is the major expansive portion of the stomach, which helps with food storage. Again, this operation acts 100% through appetite restriction. One can simply just not eat as much, to the point where it now can only store about 15 to 20% of what it was storing before. This is associated with about 60 to 70% of that excess body weight loss. Whereas opposed to the gastric bypass is more along the lines of somewhere along the 70 to 80%. So a little bit less weight loss associated with the sleeve gastrectomy. But again, that's over a population study. Each patient is their own person, and given the right motivation, every patient can do just as well as he or she wants to do. I can say that my best sleeve gastrectomy patients have lost just as much weight and done just as well as my best gastric bypass patients. One of the major contraindications, or the thing that would preclude you from this type of surgery, is having very significant reflux. Now, when I mean very significant reflux, I mean patients that are on multiple medications for their heartburn, indigestion, and still have breakthrough symptoms and still have trouble controlling it. Those patients that have a little bit of indigestion, take a pill once a day, and it's fairly well controlled, that likely will get better with weight loss. But people with severe reflux generally are not a candidate for this sleeve gastrectomy because it has the potential to make that reflux even worse. Because I've taken what is basically a low-pressure sac and turned it into a tube, which through the laws of physics would state that that would then increase the pressure in that tube, which then would increase reflux up the esophagus. In terms of the hospital course after a sleeve gastrectomy, the surgery itself is a little bit shorter. Again, the same principle holds true. Some patients do have hiatal hernias, which have to be fixed at the time of the operation. Surgery generally takes 1 to 2 hours, and my patients usually stay in the hospital about 1 night. The postoperative course is very similar. You're drinking immediately after surgery. We have our patients up and walking immediately. And again, any changes to medications will be dealt with and reviewed in detail by myself, our pharmacy team, and with the patient involved, of course. The potential risks of the sleeve gastrectomy include things like food intolerances, much like the gastric bypass, the potential for weight regain or weight recidivism, as we had talked about. We've already discussed a little bit about the potential for worsening reflux. With this surgery, there's a risk of bleeding or a leak from that staple line where I have transected across the stomach. Now, that's very few and far between. There's also the risk of making the sleeve too narrow, otherwise known as gastric stenosis, which can then increase the pressure in the sleeve, leading to a leak. Now, again, that is a very, very rare complication, but I think it's important that all patients understand that all surgeries do involve risks, no matter how rare they may be. There's always the risk of blood clots and also the potential for mortality, but again, that risk is very, very low. So now that we've discussed a little bit about both surgeries, I want to talk about what the postoperative lifestyle changes are like. When we talk about lifestyle changes, we'll talk about them through nutrition, exercise, as well as psychological changes. Some of the nutritional changes, this is obviously what is at the forefront of the success of our program, and one of the most important things, as I've illustrated before, is that accountability, that dedication to follow up and working with our program. And working with myself and our dietitian and our physical therapist, you're going to have a fair amount of follow-up appointments, and then there's also going to be things like food journaling. This can be cumbersome at times, but it is vital to the success of the patients through the program. Some of the way eating changes after this type of surgery is protein becomes very important. It's very important for one to have some element of protein with every meal and snack. Things like chicken, fish, lean beef, yogurt, cheeses, things like that become a very significant portion of the diet after having surgical weight loss. It becomes very important to limit fat and complex carbohydrate intake, fried foods, sweets, high sugars, as it can lead to dumping syndrome, but also creates what we consider empty calories. Those things do not take up any type of room, so there is no fullness. You do not get any kind of what we would call satiation, meaning you don't feel full after eating those things, as they just slide right through your sleeve or your pouch and just become calories that your body eats up and stores. One of the way things change also is the action of eating. It becomes very important to eat slowly, chewing things very well, and then also not drinking with meals. This is somewhat abnormal, especially in our society. Whenever you go out to eat, and the first thing they bring you when you sit down is a big giant glass of water. When you've got a much smaller stomach storage capacity, it's important that you fill it with the right things when it's time to eat. And by drinking a bunch of water before trying to eat, you are likely not going to have the significant appetite, or the adequate appetite, I should say, to take in the right amount of calories and nutrients. The other side of that is the importance of adequate fluid intake between meals. and avoiding things that are carbonated, as those also tend to cause bloating, and then high sugar drinks as well. It's important to always take the appropriate quality vitamins and minerals, and that is something that we will discuss with all of our patients in a very detailed fashion. Our dietitian and myself will also constantly be reminding our patients for appropriate vitamin and mineral and calcium intakes to make sure that we are avoiding any type of vitamin deficiencies. Another thing that's important, especially in the early postoperative period, is to limit or avoid alcohol. Alcohol cessation is not something that's required lifelong after one of these surgeries, but there are certain things that will not do well after having surgical weight loss. Carbonated things like beer, or high sugary things, mixed drinks, anything like that, are not going to sit very well anytime after having surgical weight loss. And almost any alcohol is probably not going to sit very well in the immediate postoperative setting. So it's just important for our patients to understand that it is important to limit and avoid that immediately, and then also at least significantly limit for the rest of their lives. The other important thing that leads our patients to success is making the appropriate exercise choices. And that starts actually in the preoperative setting. Our patients will meet with physical therapists preoperatively to start working on appropriate physical activity regimens for them based off of their limitations and what their goals are. Certain patients have bad knee pain, hip pain, shoulder pain, whatever it may be. Our physical therapists want to create a program that you can comply with and do without having to try to find workarounds. This allows us to set attainable and realistic exercise goals. It teaches proper form and allows us to give you tailored suggestions for workouts, and it provides, of course, the encouragement and motivation. Another thing that I think is very important with our program is the emotional and psychological support. Weight loss surgery impacts many areas of your life, not just from a physical standpoint, but also from an emotional and a mental standpoint. This type of weight loss changes what your body looks like. It changes how you socialize, how you eat. It changes your relationships with people. It can change how other people treat you and how you feel about yourself. That's a lot to overcome and to deal with mentally while you're also undergoing physical changes, which is why we, of course, employ licensed professionals to help our patients that are dealing with issues. We also offer support groups, which can be either online or in person, depending on how things go with COVID-19. But we're always going to have resources for our patients to better cope with the major changes that they are going through. And that will continue on for as long as the patient desires to be seen. So what are the program steps associated with this program to get you through to surgery? Well, the first one is the surgical weight loss information session, which you are now almost done with. The next step will be consultation with myself, where we will then start talking about what this program looks like, which operation may or may not be better for you. And that conversation is a two-way conversation. I greatly value what my patients feel comfortable with, but I also am going to render what I think medically is the best surgery for you. And other than a few factors that could preclude someone from a certain operation, I put a great weight on what my patients feel comfortable with. Once we do all of that, we will get you set up for an introductory nutritional class, and we will then have one-on-one evaluations with our nutrition. You will have evaluations with our physical therapist to, again, create an appropriate physical activity regimen. As part of the preoperative workup, we do also require a psychological and behavioral health evaluation. That has nothing to do with any patient in particular, but again, this surgery brings with it a lot of change, and it is important to understand what current psychological issues our patients have, if any, and that they are of good mind to cope with these major changes. People use food for a lot of different reasons. Sometimes it's used as a coping mechanism or as a way to relieve stress, and this surgery has the ability to take that away. which then leaves a void in terms of coping mechanisms, which can also be another thing that can be difficult to deal with. And so it's important that we have that side of this program as well. Once we have worked all the way through that, and what is required depends very much on the insurance company, but generally it is consecutive months of weight management with visits with either myself, our dietitian, or our physical therapist, anywhere between 3 to 6 months depending on the insurance company. Once we have reached that point, you will then return back to see me probably again for a second or even third time, and we will again confirm which surgery we think is the best for you, and we will then schedule that surgery roughly 3 to 4 weeks out to allow time, one, for insurance prior authorization, which unfortunately we cannot do until the patient has completely completed the program, and then also a 2-week, generally 2 week, sometimes 3-week preoperative diet, which is a very high protein diet that promotes protein metabolism, which will actually shrink the physical size of the liver, making surgery safer. And then surgery. And then the journey begins. I see my patients back a month post-operatively, and then you see our dietitian every quarter, so every 3 months. You see me every 6 months, and I will be happy to see you every 6 months for as long as you wish to be seen to make sure that we continue on this successful journey. There's a little bit about some of the frequently asked questions that we get. In terms of time off from work, this is a laparoscopic surgery. It's very similar to a gallbladder surgery or any other type of laparoscopic surgery in that your physical limitations are really only for about 2 weeks, which includes things like no hard straining or heavy lifting. The biggest issue in recovery now has to do more with your decreased caloric intake. These patients generally go from taking in anywhere from 1,000 to 1,500 calories, maybe a little bit less in their preoperative diet, to down to like 600 calories in a 24-hour period, and that can greatly deplete one's energy reserve. So fatigue is one of the biggest things that patients have to overcome, and for that, I recommend every patient take a month. Take a month to get advanced back up to a regular diet and create a daily routine that you feel comfortable with before adding the stressors of work back on. So generally, I encourage a month for patients after either surgery. What supplements will I need after surgery? All patients are on a multivitamin as well as calcium supplementation. This multivitamin includes high concentrations of vitamin B, which helps with energy, as well as calcium. You will also be on an acid suppression medication for the first 6 months after surgery. And then after that, that can be stopped. So lifelong, it's generally a multivitamin and a calcium supplementation. And those are yours for the rest of your life. Those can generally be found as just a standard multivitamin and calcium supplementation. These are not very expensive vitamins and can be purchased over the counter, but are very important for the rest of your life. I often get the question of pregnancy after a surgery like this. That absolutely is a safe option. The important thing, though, is to get through the major benefit period of this surgery. I encourage my patients to wait at least 18 to 24 months after this type of surgery before attempting any type of pregnancy. Pregnancy has the tendency to completely halt all weight loss. Your body is very smart, especially when it comes to creating another human being, and it will find the nutrients it needs and hang on to absolutely every calorie that you bring in and generally halt all weight loss, and it becomes very difficult to restart that weight loss if this pregnancy happens earlier on in the postoperative setting. I know a lot of patients have other questions. A great resource is the American Society for Metabolic and Bariatric Surgery, the ASMBS. There's a lot of good clinical vignettes on that website, and it presents a lot of the same information, but maybe says it in a way that is more clear than I have been able to convey today. I am a member of this society. This is the national organization which has helped us standardize and make surgical weight loss a much more safe and effective treatment for those overweight patients that have significant medical problems that are affected by their obesity. I'd like to thank you for your time today. I look forward to meeting any of you that wish to discuss things further. Any consultation with me in my office is, of course, does not obligate you to anything. It allows you the chance to ask questions about all of this, so I encourage you to write down any questions you have. If you need to, feel free to go back through this presentation and write questions down as they go. And we will sort through all that and talk a little bit about your medical history and what our program looks like for you, and then get you started in that process if that's something that you so desire. Thank you very much for your time today, and I look forward to meeting you.